Hello everyone, this video is for sharing and discussing issues of COVID-19 pandemic to provide advice for the Minister of Interior Affairs. I will mainly focus on how inequalities in health affected Black, Asian, and minority ethnic groups by giving evidence and literature from a global perspective. I will also explore on why these problems exist and making explanation for the determinants and related factors. I will also suggest some possible policies that the government can make efforts on improving this situation based on my personal perspective, and conclude with a rationale for one of the suggestions. Looking at the COVID-19, it has evolved rapidly into a pandemic with global impacts. However, as the pandemic has developed, it has become increasingly evident that the risk of COVID-19, both in terms of infection rates and particularly of severe complications, are not equal across all members of the society. While people identifying with Black, Asian, and minority ethnic groups have disproportionately higher risk of being adversely affected by COVID-19 in the global area, the BAME groups often face inequalities in various aspects such as limited access to healthcare, higher rates of poverty, and higher prevalence of underlying health conditions, which increase their risk to the virus. In this section, I'm looking at 3 difficulties that Black, Asian, and minority ethnic groups may face, including poor clinical outcomes, existing non-communicative disease, and occupation risk. Also, I will talk about how ethnic, socio-economic, and geographic disparities are connected with this problem. The Public Health England have reported that Black, Asian, and minority ethnic groups are more likely to be tested positive and poor health condition and mortality rates during the pandemic. Therefore, inequality of health in COVID-19 occurred in ethnic minority, and it can be seen as a related issue of the pre-existing disparities. The second problem is that the COVID-19 pandemic is occurring against the backdrop of the previous inequalities in non-communicable disease with inequalities in the social determinants of health. For the most disadvantaged communities, COVID-19 is seen as a syndemic. It is a co-occurring pandemic that interacts with and exacerbates existing chronic disease and social conditions. Racial and ethnic minorities, individuals from low-income backgrounds, and disadvantaged groups are more likely to experience higher rates of chronic disease due to social and environmental factors. There is only the COVID-19 pandemic seriously influenced the poor health conditions, but also a syndemic exacerbates the situation. Essential workers have faced numerous challenges during the COVID-19 pandemic. Healthcare professionals, emergency responders, grocery store employees, delivery workers, and others have been at a higher risk of exposure to COVID-19 due to the nature of their jobs. This increased risk puts essential workers at a higher likelihood of contracting the virus and transmitting it to their families and communities. In the early stages of the pandemic, there were shortages of personal protective equipment such as masks, gloves, and others. Many essential workers face challenges in accessing adequate protection, leaving them vulnerable to infection. Even when the protective equipment became more available, ensuring a consistent supply and proper usage remained a challenge for them. Moreover, essential workers have experienced increased stress, anxiety, and burnout due to the demanding nature of their work during the pandemic. They have been working long hours, often under high-pressure conditions, while dealing with the fear of contracting the virus or transmitting it to others. The risk of death for ethnic minority groups is one of the most severe health inequalities in recent times. Between March and May 2020, populations from all ethnic minority groups, except females of Chinese background, are at greater risk of dying from COVID-19 compared to those from white backgrounds. Data from England and Wales found that people from Black, Asian, and minority ethnic background made up almost 30% of the people with severe COVID-19. Only 14% of the population in England and Wales is from a BAME background. A third of patients admitted to intensive care units over the age of 19 are from an ethnic minority background. People living in socio-economically disadvantaged area, the poor, and the other marginalized groups. For example, homeless people, prisoners, and street workers tend to have more coexisting non-communicable diseases, which are more severe and appear at a younger age. Consistent associations were found between low work status, for example, low control and high demand work, stress-related morbidity, and a variety of chronic disease. In the COVID-19 pandemic, this problem caused a high rate of infection among the BAME groups. An example is that in a large cohort in Louisiana, almost 80% of the patients who were hospitalized with COVID-19 and almost 70% of those who died were black, whereas blacks comprise only 30% of the health population. Further, Black, Asian, and minority ethnic minority workers are overrepresented in the lockout sectors. The figure in the right shows some of the occupations with the highest age-standardized mortality rates of COVID-19. For example, drivers and security guards feature a high proportion of BAME workers. Over 50% of all deaths reported within the NHS are caused by medical staff born outside of the UK, who make up less than 80% of the NHS medical workforce. This problem in COVID-19 were caused by various aspects, including the social determinants of health, role of comorbidities, and paradigmatic shifts. World Health Organization defines social determinants of health as the conditions in which we were born, grow up, and live. There are damage occurred from these determinants during the COVID-19. In this section, I will specifically discuss some of the social determinants, while others are not to be explained in details. Since the economic gap between rich and poor tend to increase, the poor are likely to become poorer and inequality to increase. People in higher paying jobs may see their incomes increase if they can work from home. Those in lower paying jobs will either have to go out and take what may be frontline jobs or lose their jobs and much of their incomes. Preschoolers whose early childhood institutions are closed are affected by rising rates of child poverty and go to bed hungry. School-age children, the blockage among them increasing the educational divide. Children from poor families falling further behind the mental health of young people, deteriorating. Unemployment is on the rise, and those in employment face an uncertain future as work-leave schemes come to the end. The nature of work has completely changed for better or worse. Overcrowded housing and lack of green space, which was a problem before the pandemic, became more prominent during the pandemic. Calls to helplines reporting domestic violence have increased. Prior to the pandemic, there was a national focus on loneliness, particularly among the elderly. During the pandemic, the problem became more acute. The physical structure of communities, such as close distance to resources like grocery stores, green space, the mix of business facilities and housing, affect the COVID-19 pandemic. High-density housing and group living quarters accelerate transmission of the virus, disproportionately affecting older adults in nursing homes and people with compromised health in overcrowded communities. Blacks relative to whites are more likely to live in neighborhoods with a lack of healthy food options. Facility, safety, and lighting. Blacks are also more likely to live in densely populated areas, further increasing their contact with other people. Blacks represent about a quarter of public transit users, which may affect accessibility to testing sites. This neighborhood characteristic make it more challenging to maintain physical distancing and self-guarantee to curb COVID-19 transmission. Damp housing can also lead to bad outcomes such as overcrowding can result in higher infection rates and increased risk of injury from household accidents. During COVID-19, members of minority groups may be at greater risk of infection because they are workers in important industry who must continue to work despite an outbreak in their community or because of their economic situation. Regarding to the access to healthcare, it is a basic human right, but the strain of the COVID-19 pandemic on the healthcare system has affected primary care services for many people. People who believe they are infected with COVID-19 need to seek testing or immediate medical care. Language and cultural barriers is also a factor that influence BAME group. Patients with language barriers often experience poor patient clinician communication and worse health outcomes. People with comorbidities such as hypotension are more likely to be affected. Paradigmatic failure refers to shortcomings and limitations of existing systems, policies, and approaches in addressing the needs and challenges faced by marginalized communities. As a result, intervention and policies may not effectively addressing the concerns and needs of the BAME population. This will be further discussed in the next slide. There are a number of ways that the government can respond to improve the situation that I mentioned. Public health policies sometimes are not successfully implemented. For example, the UK government was widely criticized for its response to the epidemic, which included poor decision-making, delayed implementation, and poor enforcement of embargo measures, abundance of testing, shortage of key resources and adequate testing and tracking methods. The focus was seen to be less on acting quickly to save lives and more on protecting the economy, and the government was seen to be an increase in poverty, suffering, debt, instability, homelessness, unemployment in order to do this. While there appear to be concerns with the government about the political acceptability of shutting down the country, the government has failed to provide sufficient support for people to self-protect, and despite some limited financial support for the self-employed or those have been laid off, and a modest increase in welfare payments, many people are struggling financially. More and more people are facing food insecurity, and pandemic provide conditions that push those who can just cope into crisis and poverty. In Europe, governments prioritize their own interest even if this undermines solidarity with other countries. Ensuring equitable access to COVID-19 testing and healthcare service is important. Establishing accessible testing centers in areas with a high BAME population density, including mobile testing units, can help overcome barriers to testing. Additionally, improving access to healthcare services through community health clinics, telehealth options, and language interpretation service can help address healthcare disparities. This data can help identify disparities and inform targeted intervention. Regular monitoring of health outcomes among the BAME population can guide public health responses and ensure accountability in addressing health inequalities. Governments can invest in digital infrastructure and provide access to technology and internet connectivity to ensure remote learning opportunities for all students. As for community development, government can provide financial support to community development organizations and non-profit entities working to address the needs of marginalized communities. This can include funding for job training programs, small business development, and community initiations. Regarding these possible assistance measures by the government, I think it is good to increase funding for social health elements, especially education and employment. The government can protect the labor market and support families to sustain business and employment through containment, more protection, adequate income provision, and encouragement in employment for BAME workers to prevent poverty, illness, and loss of status. Financial support, mentorship programs, and access to capital can help foster enterprise and economic empowerment within the BAME community. This can contribute to reducing income inequality and increasing financial resilience during the pandemic. Education funding supports the implementation of health and safety measures in schools, such as improving systems, providing personal protective equipment for staff and students, implementing regular testing protocols, and enhancing cleaning and sanitization practice. To summarize, increased funding for employment and education can contribute to reducing inequality and promoting social mobility within the BAME group. By addressing systematic barriers and providing equal access to resources and opportunities, governments can help level the playing field and create pathways for upward social and economic mobility. This in turn can lead to improved health outcomes, increased community resilience, and reduces disparities in COVID-19 impact. I hope I have expressed my thought clearly and provide useful insight into reducing the harm caused by COVID-19 for disadvantaged group. Thank you for listening.